Hey, Rohan, are you there? Are you in? Okay, that's fine.
Hi,
Hey,
yes. Is my voice audible?
yeah, how you doing? Is this Rohan?
Yeah, doing good. I'm just preparing for my presentation to have logged in on my laptop, my uh,
Okay,
tab and
you want to test
share.
it? You want to test it now?
Yeah,
Yeah, go
yes,
ahead.
I want to.
Yeah, go
Yes,
ahead and
yes,
test it.
yes. Just give me 5 minutes.
Yeah, sure. No hurry. We got plenty of time.
और अभी 15 मिनट में ज्वाइन करना. Sorry, Dr. Bennett. I have the panelist which I have asked to come join. Those are neurosurgery residents from University of Belgrade. I'm not sure who one of them are going to join. Which one of them are going to join because I've requested for around 4 to 5 neurosurgery residents. If any one of is available like that.
Okay, they're welcome to join.
Uh, yeah, just okay.
Tell your mother
No,
to
I
come.
was
Is your mother around?
so sorry.
Your mother.
No, not my mother.
Well, she can come, but
Neurosurgery.
she should be proud of her son.
Yes, she can
He's
join
now
it.
on the internet.
Yeah, it's just that the time zone is different. I'm in Serbia and she's in India, so
Oh,
it's
okay.
like
CET versus IST.
yeah, it's sleeping time like there. It's
Oh,
maybe
it's
12 a.m.
right now. It's about 11 o'clock there. Yeah, 12 o'clock.
Yeah, to almost about to.
But a mother would watch her son anytime. Come on, wake her up. Well, wake her. Is your father still living? Okay, we won't talk about that. Hey, Ray, is that you? When I hear that sound, I know that someone's on both YouTube and Zoom at the same time. When I hear that echo, yeah, so that's okay. Ray, hello, Arthur.
Hi, good afternoon, good evening.
How you doing?
Good.
So you're all set for Tuesday, right?
Yeah.
I mean, is it Tuesday? Yeah, Tuesday's
Yes,
the next
on
one.
Tuesday, 24th.
Yeah, you got 300 interactions from YouTube, right?
Yes.
Well, I mean, that's kind of what I thought. I thought that I was at like an impasse. I could either televise it on the front page of neurosurgical TV, and therefore I lose people because they just browse the net, they see it on my website. I have no way of showing advertisers that they watched it. Do you know what I mean? I don't have any hard evidence that they were there.
Right.
But I figured, well, it's convenient. I might as well just do it. I'll just take a hit on the numbers and I try to explain it. And
Right.
hopefully they'll understand that we're just not building numbers artificially. Well, these are real numbers.
Yeah. So we need organic members attending us. We don't need fake numbers.
Yeah,
That's
I was thinking, yeah, we gotta get some real dynamic students, med students. Do you know what I mean? Like we'll run into them, like they're crazy like me. They just like the internet, and they live on the internet. We gotta reach those. They're out there. We gotta find them. I gotta find them.
yeah.
You have a job.
Yeah. So from our end, the presentations should become gradually better in quality, so people will.
Well, we will. Arta, I got some great news. I
Mm,
got a good connection of an Indian neurosurgeon in the United States that loves education and she wants to give back to her country of India. So, wow, that opens it up, the English channel, because all I need is someone like that to start it. She or one of her Indian American associates will put a series together. That's what we try to make it continuous so that the
mhm.
students can watch it and have track of what they're doing. essentially,
Mhm.
with a, with a good webcast,
Mhm.
evidence-based webcast that of the syllabus that you guys are going to put together for the students, so that they know that hopefully every week they have something that they can go to and build on. You know what I mean? I don't have to explain it to you. So
I understand, yeah.
we're going to be the MTV
Okay.
24 hours a day.
Yeah.
Hey, that's how they started. When those guys started, everyone thought they were crazy. They thought music 24 hours a day. Come on, give me a break. But man, they broke all kinds of barriers.
Mhm.
Okay, you haven't met Rohan. Lee, Rohan,
Uh,
say hi. Say hi to my co-conspirator, Atabati. He's a neurosurgeon from Geneva, Switzerland.
Hi, Doctor. Greetings, Doctor Atabati.
Hi.
Nice
Hi,
to meet
Rohan.
you.
How are you?
Hi. Good, good. How are you?
Good.
He's training, he's a dual neurosurgeon,
Your
endoscopy and
neurosurgeon.
operative,
Okay.
right, Ata?
Yep.
Yeah, and hopefully we'll start that channel, the dual. I didn't plan that. It just happened. When he came and said he had a bunch, he says 50, but I would say 10. If someone says 50 to me, I translate it to like 10 or less, because not everyone comes that says they're going to come.
That's right.
Okay. You're just playing with it, right, Rohan?
When I start, yeah, I'll just give a quick overview. Just
Yeah,
let me
that's
know if
good.
I have.
Okay, yeah, basically, that's how I ran across Rohan Atta. Is I was just browsing the net and I saw the presentation of Subdural, and I thought that would be a good topic to lead students through, and Rohan agreed. So, and his presentation is already done before we even started.
Rohan, are you focusing on acute subdural or is chronic subdural included in your presentation?
I'll just give a brief summary about acute subdural and chronic subdural.
Mhm.
As a medical student, what I understood, like acute subdural hematoma, please correct me if there is some
Yes.
addition to
I
it.
want to,
Uh,
I want to stress that to Atta. Feel free,
Mhm.
Atta, if you feel you can add some insights. I'm sure you have a million insights. I mean, and you don't be afraid to interrupt Rohan. Okay, Rohan?
Sure.
Yeah, he may put some clinical, whatever. Just do
Yeah.
what you feel would help the presentation based
Yeah,
on.
sure. Sure. I'm here to.
Yeah, interactive, make it real interactive, going back and forth. Oh,
So what we have in acute subdural hematoma, it is right after the injury. The symptoms will occur like 2 to 3 days. Uh, Basically, it occurs 2 to 3 days after bleed. Symptoms will be nausea, headache, and coma. That are the very brief points which I had included in the acute subdural hematoma. What are some more things which I can mention?
okay, it's up to you guys. You guys decide.
Let's just hear you first, just without any distraction.
Without
You
limitation,
go
okay.
whatever your presentation is. So let's just
Yes.
go through that, and then we um, relook into further
So
discussions. So
yes.
okay,
So
so
what we
don't worry.
have, okay.
Don't
Then
worry, just go through, because the whole point of having medical student forum is to bring medical students and junior residents. So they have more freedom to express whatever they like to, because there are less stakes involved if the medical students are entering into this domain. So don't worry, this is the time you can correct your course if you have some concept which needs review. We are here to support you. Okay. So don't be afraid of making mistakes.
Yes, yes.
Yeah.
You know, my brother asked me what I did during these webcasts. And I said, well, I'm like the janitor. I turn on the lights, I take out the trash.
Mhm.
And you guys put on the show.
Yeah.
And that's honestly, that's what I do. But that's okay. I'm happy with that. Very happy with that.
Mhm.
So
This-
I'll just go briefly what we know about subdural hematoma. Subdural hematoma, it is present below dura, as the name suggests, and hematoma is basically a blood collection below the dura mater. It is one of the common neurosurgical conditions which could occur due to the tearing of bridging veins. So to understand the concept of subdural hematoma, we need to know the layers of the skin. We have the scalp.
We're not starting now, right? You're not starting, are you?
Not starting, just giving like
Oh, okay,
uh,
okay. Sorry to interrupt.
like
Just we have 10 minutes.
10
At
minutes.
the
Yes.
beginning, Rohan, I'm going to take you off the screen share so we can see your face. Because
Oh,
part of the value of this, as Arthur will tell you, is the recognition, facial recognition is going to be a
yes.
big thing in your career. Because people feel that they know you, if they know your face and they've seen you interact. Whereas if it's just a name, a black name, and we don't even see your face, it's not good. I mean, because networking is the value of this platform. For you to network, your career is starting, and you want to meet people like Ata, so that you know them, and they know that you're serious about your education by leading a group like this. You know what I'm saying, right,
Yeah.
Rohan?
Just give me a minute. I will. I have been joined by another. Can you make the other participant, which is
Yeah, I'm
mm,
gonna take you off this. You're gonna go off the screen there, right? I'm gonna take you off.
useful. So can you make RM the panelist as well?
Oh yeah, he is the panelist. He's in the panel. He's at front row seat.
Uh,
Okay, am I pinning you? No.
RM, the other participant, like this one. RM, he's in attendees, and
Let me
Yashpal as
check.
well.
Let me check. You may be right. Okay, let me check.
There are two
Oh,
people.
Yas is here. Okay, he's the
Will be delivering the next talk.
moderator.
RM, yeah, make him the panelist so that I can
Yeah,
join by the.
he's coming in. Okay, very good.
Is my yeah, yeah. So I'll be
Okay,
doing like this.
RM.
Is myself. It's myself. It's just that
Oh,
I'm.
okay.
Yeah.
Are you, yeah, is Yash, are you using the same, a different
So
screen?
uh, yeah, same university. So he will be delivering the next talk on the spinal care for that.
Okay, so can you put your right name there, Yash? In the RM instead of RM?
No, it's me. RM is me.
Oh, okay. Yash, are you there? I'm sorry.
Good evening, sir. Yes, I am.
Yash, that's your name. I don't see your picture.
Oh, picture?
Yeah,
Just
yeah, your photo. Okay. Oh, there you are. Okay.
Hello, sir. A very good evening to everyone.
Nice to meet you.
Nice
And
to
you
meet
know
you,
what?
sir.
You said the magic word to me. I need to do some work. Man, that was like music to my ears. Because you can help. You can do what I'm doing. You can lead the webcast. You know
Yes,
how
sir.
to do it. You know you played the game in medicine for a while. You know the game.
Yes,
So
sir. Yes, sir.
you could run this basically. Anyone can run it, really. So
Yes. Thank you. I'll gladly be able to do that.
okay, with 7 minutes we start. There's usually a rush of people at the end. Not a tremendous big amount, but yeah, what we're trying to do, Yash, I've gone over this with Atta, is to try to network with Indian neurosurgeons that are practicing in the United States.
Yes.
A lot, that's what we're trying to get a channel, strong channel to connect to the United States. And using most neurosurgeons, as you know, they would love to teach in their country to make sure that they're improving and are privy to the latest technology that's happening there. So, and then we're going to help get people like you to help spread the word about the webcasts, and they're going to be regular. One thing that really made me angry, like it did to Atta, is the fragmentation of the talks. There's no organization. It's just a bit here, trauma here, tumors there, and there's no organization. But we hope to make it organized so that like every week or every, a couple times a week, hopefully, you'll go visit something that part of a series. So
Wonderful.
you kind of build on the knowledge. I think it's gonna work.
Yes, sir. I'm very optimistic about it, and I do believe that it can work like this. So,
Yeah. I could really use the help because we're gonna have more webcasts. We're definitely gonna have more webcasts. Uh, I'm not in a hurry. Been doing this for a while, especially in India. It took off initially in India and Pakistan. Those are the two places in the whole world that really, and then actually Latin America too. They had a pretty good interest. So I'm talking too much. You guys talk. No, I don't know how people can put regular shows on and talk the whole time, uh, unless you have a topic like neurosurgery, of course. But if you're just like having a meet and greet session, it's not easy to keep conversation going for an hour. I mean, you always have neurosurgery in this format. So far today, we had a webcast from Yemen with two board certified people from the States. It was really good. And they're pretty regular. They've been doing webcasts for a couple of years now. Yemen. They're a leader, actually. I wish there used to be a thing called co-host in the Zoom. Did you ever use that?
I don't think it's the option currently.
Yeah, I don't think
have
you've
it,
ever seen it, but maybe other people, Yash can tell you that there used to be an option for me to make you a co-host.
Oh,
And you were able to let other people in and look at the questions, but they took it away.
yeah.
One day, Zoom will do that. They'll just do things, and it's like, whoa, wait a minute.
Mhm.
Not huge changes, but they're the game in town. They're the best. I
Yeah.
mean, they're keeping up and making it's still simple. I mean, did you ever use Google Hangout? Or you use Google Meet, I know, but you
Mhm.
ever use Hangouts?
Not yet.
That was a difficult one to use because it was hard to explain to neurosurgeons. They just didn't, we would convince them eventually to try it and then jump on board and then the Zoom came.
Mhm.
And it's a big change, big change. They got established, and then the pandemic. Man, what a boost to their business. It went up 20 times in one day,
Mhm.
viewership. 20,
Yeah.
imagine that, having a business, it goes up 20 times in one day. They just
Yeah.
came at the right time.
Co- COVID has changed the world, and during those days, neurosurgical people had no elective practice, so they were either doing emergencies or they were available.
Excuse me, I'm going to get ready. We're going to start in a sec. Okay, Yash, are you
Yes,
ready?
yes, sir, absolutely.
Okay, and Rohan, you ready? I don't see your
Yes,
pictures,
sir.
you guys.
Oh, I'm not so
Yes,
sure.
I'm
Yeah, I believe now you should be able to see me.
Okay. Yeah, there we go. I'm going to introduce you. We'll teach you. You know how to do put a background on? Yes.
Yes, sir.
You can put one on in the future, if not today. And okay, we're going to start. You ready, Rohan? Can I see your picture? Got to introduce you.
Yes, let's start.
Okay, I need to see your picture, Rohan.
It's on via my other, if you can see me.
You can't.
I have joined by
You can't put
I
your
have joined
finger
by
on.
two. It's not. It's just that.
Okay. Okay. Well, we'll set it up before next week. We'll get it next week. Okay. But generally, I like to explain. Oh, there you are. There you are. Okay. I just got to introduce you, and then it's all good. Okay. Here we go. Record 10, 9, 8, 7, 6, 5, 4,
Yep.
3, 2. Good morning, actually good afternoon from Miami Beach. This is Dr. John Bennett broadcasting from beautiful Miami Beach, home of neurosurgical TV. Today, we have a broadcast of, I bumped into this, going on the internet. Rohan's been doing this for a while, so he agreed to do a series, and we're going to start today. But first, we had a gentleman that just jumped on the hosting position, Yash Pal. He's also a medical student, and he'll introduce himself, and then he'll introduce this Rohan, speaker. Good day, Yash.
Yes, sir. A very good evening to all the viewers and the panelists. My name is Yash. I'm finally a medical student in the University of Niš, Serbia, and I'm glad to introduce my good friend and the future neurosurgeon, by God's grace, Rohan Mane, who will be hosting today's webinar. So his topic is about subdural hematoma, and he'll be taking over and going through all the concepts and all the important things based on pathological side of it, as well as the more anatomical side of it that we can see in diagnosis, and how we can actually go through it in terms of dealing in clinical practice. So over to you, Rohan.
Thank you, Dr. Yash.
Excuse me, Rohan, I erred. I should have introduced Atabati. He's a dual, he's a neurosurgeon from Switzerland, and he's going to be here to lend his expertise. Okay, away you go, Rohan.
We also have a panelist, Dr. Marco from University of Belgrade. So now I'll start my video. So for subdural hematoma, what it is basically what it means. Sub means below the
Can you
dura
make it full
mater.
screen? Can you make it full screen, Rohan? I don't know if it's full screen. See if you can make it full screen.
Is it okay now?
Yeah. No, there's no option, full screen? No?
See.
Okay, well, just decrease the size of the font, and that's fine. That's fine. Okay. Whatever makes you
So,
comfortable, okay?
yes. So subdural hematoma, it is basically the hematoma which is present below the dura mater. Hematoma is basically a blood collection, and we have the layers of the skin starting with the scalp, the dura mater, in which we have the uh, periosteal layer, and the inside, which is the other inner layer of dura mater. After that, we have the arachnoid and the pia mater. So between the dura and the arachnoid is where the hematoma getting collected, and this is referred to as usually the subdural hematoma. It is usually caused by the sub-bridging veins which is present. So here we can see the subdural cavity, and this subdural cavity which is present between the dura mater, which is here the yellow layer, and the arachnoid, which is present here as the green, and in between it we have the subdural cavity in which we have this bridging veins. These are the bridging veins which are prone to rupture when there is a traumatic injury. Basically, usually we say it as acceleration deceleration injury, where the head moves ahead and back, and it usually leads to the rupture of those breathing veins and leading to the formation of hematoma, which is the collection of blood in this layer. Usually we say that is the basic idea what we have regarding subdural hematoma. That is the blood collecting between the brain and skull. It may be a small area of bleed where the veins are torn. There is leaked blood leading to increased ICP and the blood applying pressure on the brain. So it is one of the common neurosurgical condition, as we mentioned, due to the tearing of bridging veins. Etiology can be traumatic, in which there is head injury, example motor vehicle collision. Um, Usually patients are elderly who are on anticoagulant medication or blood thinner medication or antiplatelets, and these elderly patients are also at uh, risk of cerebral atrophy, since with age there is the atrophy of the brain, which leads to the stretching of these veins and these bridging veins. So due to it, they are more prone for the subdural hematoma. The other reason could be falls, can also be seen in sports injuries, like in case of football, where they have head-to-head collision. Other uh, cases in pediatric patients could be shaken baby syndrome, um, due to the fact that children have a thin cerebral veins also, and due to the uh, basically shaking of the baby leading to the cause of rupture of those bridging veins, which are thin and leading to the formation of subdural hematoma. Some non-traumatic causes, as we mentioned earlier, were the medication, like non-traumatic can be coagulopathy. Also, there can be CSF leaks leading to intracranial hypotension, and these intracranial hypotension may be due to the sudden or increased amount of CSF drained out via lumbar puncture, or there can be either due to extraventricular drain. Other cases can be in case of other cases of subdural hematoma, we can have differential diagnosis as aneurysms, arteriovenous malformations, and tumors. Some common symptoms which can be present are loss of consciousness, which is a very general symptom. Then there can be headaches, which can be dull headache or severe headache. There can be nausea, dizziness, pulsating headaches are some of the other common symptoms. Treatment depends on the signs and symptoms. The bigger the hematoma, the urgent neurosurgical care be delivered to the patient. Some treatment modalities which we have is utilization of burr hole procedure into the skull, and clotting the blood vessels which are leaking, craniotomy, which we do. These are few steps in the procedure. We open the scalp, drill out the part of the skull, open the dura mater to access the brain. Uh, we aspirate the blood which is present, as well as clot the blood vessels which are leaking. Uh, if the hematoma is smaller, we can monitor the patients. And the usual method of diagnosis of a patient who has underwent a recent traumatic brain injury would be to first do a non-contrast CT scan of the head to rule out the subdural hematoma. So there can be various time frame in subdural hematoma. We have acute subdural hematoma, which could occur right after the injury. The symptoms could last 2 to 3 days after bleed. Here I have mentioned some general symptoms like nausea, headaches, and can also lead to coma if not uh, dealt emergently. Subacute subdural hematoma, there can be bleed which can be clogged up and can also have the exudative fluids. Symptoms can last from 4 to 21 days. In the chronic phase of subdural hematoma, we have clotting of blood along with inflammation and formation of granulation tissue. It develops over weeks. The symptoms are tiredness, confusion, and memory problems. So here we mentioned the basic idea of subdural hematoma, the introduction, the etiology, the symptoms, and the treatment. Some of the CT images which we can see are of here acute subdural hematoma, where we can see hyperdense bright white crescent shaped collection which is present between the left side of the cerebral hemisphere, and the basically bright white color here is signifying that it is a fresh bleed. Again, then later we have this indicating the subacute phase. In the subacute phase, we have the isodense collection over the right hemisphere, compressing the right lateral ventricle, and it is not as white but not as dark. So it is in between, and this is the subacute phase. Then we have the chronic phase. Here we can see it is mostly it is dark, which means it has been quite a while uh, for the blood to be in the brain, and it would be more than 3 weeks. So those are quite a few points, some points for distinguishing the time frame of subdural hematoma. Then we can also see is the midline shift. Midline shift is basically here in the center. What we usually have are the lateral ventricles. So if those lateral ventricles are shifted from their normal position, it is referred to as the midline shift. And it usually occurs in subdural hematoma. So here in the chronic phase, we can see that what should have been the midline and the connecting point between those two lateral ventricles, it have shifted towards the left hand side, so towards the right. So that is one of the feature of subdural hematoma. There are few other hematoma types like epidural hematoma, which is usually caused by arterial bleed, and it can be from skull fracture. There is rapid bleed between the skull and the dura, and causing the etiology is middle meningeal artery. In subdural hematoma, as we discussed, it is broken bridging veins, and it is slow between the dura and the arachnoid mater. In craniotomy, we remove the skull and evacuate the blood, and so there are two conditions in which we do to treat subdural hematoma. One is known as craniotomy, where we remove the skull, we evacuate the blood, and we replace the skull. But in case of craniectomy, we remove the skull, we evacuate the blood, but we keep the skull open, and we ask the patient to return back to the clinic so that the skull can be put back on place. And basically, what we try to achieve by keeping the skull open for a few days is to allow the brain to swell and decrease the ICP, and that may be helpful. So we have subarachnoid hemorrhage, which is between the pia and the arachnoid space. It is referred to as the worst headache of the patient's life. The symptom in case of subarachnoid hemorrhage are projectile vomiting. So that, and a principle which is relevant to while discussing the cranial space is Monroe-Kelly doctrine, in which states that 80% of brain, 10% of blood, and 10% of CSF is present as the skull content. There can be increased ICP, that is the intracranial pressure, and that mostly would be either due to the increase in the blood due to a traumatic rupture or increase in CSF in case of, I think, hydrocephalus. The symptoms will be headaches as well as some neurological symptoms, depending on where the herniation is occurring. So we also have something called Glasgow Coma Scale to determine the severity of subdural hematoma. 15 is our normal regular patient. 13 to 14 is requiring care. 9 to 12 is requiring urgent care, and less than 8 it is a very severe state of Glasgow Coma Scale, to require an emergent neurosurgical procedure. So what we do by if we have a patient of subdural hematoma, we try to intubate to prevent the hypercapnia. What hypercapnia is, there is increased CO2 count, increased CO2, and this CO2 usually leads to vasodilation of the blood vessels in the brain. We don't want to increase the ICP more, which is already increased due to the leaked blood into the closed cavity, that is the skull. So to prevent it, we try to intubate the patient and try to prevent basically vasodilation and in turn an increase in ICP. There is something also called as Cushing's triad, where we have increased blood pressure. There is irregular breathing as well as decreased heart rate. So these are triad of Cushing's triad, and some points regarding the types of herniation which we had. So the herniation, basically we have Fox cerebri here in between. Just to make sure I say it correctly. So we can start with the cingulate, that is the subfalcine. The cingulate gyrus, it is pushed under the Fox cerebri, and on CT, it shows as the midline shift, and there is compressed lateral ventricle. In case of the subfalcine herniation, that is also known as cingulate herniation. In case of uncal or transtentorial, there is a medial temporal lobe shift towards through the tentorium. So the uncal herniation, there is medial temporal lobe, which is the medial aspect of the temporal lobe shifting into the tentorial cavity. CT sign will have a dilated contralateral ventricle. So the ventricle, which is the lateral ventricle, may be dilated, and there will be compressed midbrain. In central or downward transtentorial herniation, the diencephalon or the brainstem shifts downwards. There can be obscured basal cisterns as well as durate hemorrhages, which is present in pons. Mm, in tonsillar and cerebellar, the cerebellar tonsils herniate through the foramen magnum and can cause the obstruction of the fourth ventricle, leading to hydrocephalus. And the last which we have is upward cerebellar, where the cerebellum transfer ascends through the transtentorium, and it can be seen as quadrigeminal plate cistern. On the transcalvarial side, the brain is protruding through the skull, and it usually occur post craniotomy. So these were few of the points regarding subdural hematoma. The thing which we did not cover was this brain herniation. It can also lead to ipsilateral dilated pupil as a neurological sign by compressing the nerves which are present. So this will be it as a talk for subdural hematoma. If you have any questions, please let me know. Or any corrections or opinions. Thank you.
Okay, thank you, Rohan. Very good effort. Anyone who wants to comment, question first, and then I would like to share some points. So I see Byam and if you have anything, any comment, any question.
I just want to thank the presenter. Thank you so much. That was really good for a medical students level. Started from the very basics and included some neurosurgery. So I really appreciate it. I'm a medical student, so that was perfect for me. Thank you so much.
So it would be interesting if you could introduce yourself. Where are you from and which year?
So I'm Payam Sido. I'm a final year medical student at Al Faisal University in Saudi Arabia.
Okay. Thank you. So, Yash, you do have anything to comment? Do we have, John, do we have any other attendant? I mean, any other person who's not in panel and wants to ask any question?
No questions from my side, sir.
Okay, so basically, you have done a very good effort, but I'm not sure how much exposure you had in terms of clinical rotations, emergency, elective neurosurgery. So you tried to put too many things in your first talk. So I think I would advise you better to go slow. Don't try to just incorporate everything, every concept in one talk. And remember that if your basic concepts, basic anatomy is strong, then you would be more safe emergency doctor, or you would be better and safe. So my message is know anatomy first, go to very basic things like subdural. I can see two different diseases, to different patients, to different mechanisms. And that's where the problem arises, because the acute subdural is an acute trauma disorder, traumatic brain injury. And it's usually in young population, most commonly road traffic accident. There can be other causes of this acute subdural, as you mentioned, the subaqueous hemorrhage, but those patients are very small chunk of acute subdurals. So mainly when you divide acute subdural and you want to describe those, then acute subdural has further two main groups. The one is where it's a traumatic. Traumatic can be a road traffic accident, fall, some assault, etc. And non-traumatic could be AVM bleed or aneurysmal bleed, and very few people do present compared to the traumatic one, which is a big chunk of what we deal in emergencies, right? So that's the first and foremost important thing. And when I say that usually we see young people with trauma in emergency room, it can be the elderly patients. So the difference between elderly and young brain is, as the age advances, there is a shrinking of brain, which we call as atrophic brain. And you mentioned that there is a subdural space. So in young people, or in even in elderly, subdural space is a potential space. In a normal healthy brain, in a normal healthy situation, on a scan or in a anatomical layers, you won't find subdural space as a different space. So can you describe the layers of dura here? So it's a schematical diagram. So can you just point out which layer is where?
So in the yellow, what we have is the dura.
In
This
the
yellow
yellow.
layer is the yellow. Yes. Here we can see this is pointed as dura mater, and then we have the arachnoid matter.
See, my focus is again, the subdural is not a space, is normal, normally present. So when something happens like acute subdural hematoma, then this space becomes visible. Like in normally the full brain in young people, you have two layers of dura. So there are two layers of dura. One is periosteal layer, which is very adherent to the inner vault of the skull, right? So if this is the calvarium, the skull bone, so can you see my pointer?
Yes. Can you please now do?
Can you see my pointer? No.
No.
Let me share my screen.
Yes.
John, if
Yes.
you allow, I can share my screen.
You can go ahead, Dr. Bhatti. Yes.
Can you see my screen now?
Just a minute. It's sharing.
Okay, just wait. So the skull has two layers. So the outer and the inner one. Skull is also called, skull bone is also called as calvarium. So that there is an outer table and an inner table, which are hard cortical bones. And in between those thin layers, there is a spongy in between. Can you see my screen now?
Yes, it is visible. Yes.
Okay, let me just take you through. Okay, let me find out the appropriate image so I can show you. It's not moving. So in fact, the inner layer of the dura is very adherent to the inner skull. So do you understand where the inner skull is? Where inner, if we consider skull as a box, there is an outer surface, there is an inner surface. So the skull bone itself has a outer table and inner table, right? So
Yes.
so the okay, just let me now you see the pointer. Let me explain this
Yes.
thing. Okay, so this is MRI T1 weighted images. Okay, it's a axial cut. So on the superior side, it's the frontal pole. On the posterior side, it's occipital pole. This is the midline, right? So the white thing, which on MRI is called as hyperintense, is the scalp, the skin, the thick skin having 5 layers. So that's not the subject today. And then the bone is not that CT hyperdensity like appearance on MRI. So here you can see the grayish brain, the grayish white brain frontal gyri are visible. So this is the superior frontal gyrus as seen on the left side and labeled as well. So you can also see the middle frontal gyrus here, and you can see the motor strip area. So the precentral gyrus, motor strip, cortical sulci, and hand knob area is visible. So when you see the space between the inner part of the calvarial cavity, so the dura has two layers. So one is very adherently stick to the inner part of the calvarium, the inner skull bone, and the out the that's the dura which we call as periosteal dura, and the other thick layer that curves around that insleeves around the brain, and in the midline, the first space you see in the midline is a triangular space which accommodates the superior sagittal sinus, and in the similar fashion all the sinuses are being created by the sleeves of the dura, the thick dura. And then comes the arachnoid. Arachnoid is a very thin transparent membrane, and it follows the sulci. So these sulci are visible here with the intergyral spaces. You see the sulci, and the subarachnoid is a transparent, just like a cornea You can look into the iris exactly in the same way. In a normal brain, you can see inside the gyrus, the gray, the yellowish brain gyral patterns are visible, and through the transparent arachnoid membrane. And the pia membrane adherent to the brain parenchyma, and it follows all the contours of the gyral. And the blood vessels are present in the subarachnoid spaces, right? So the major blood vessels, the circle of Willis, so that is the reason why the subarachnoid hemorrhage leads to the cisternal subarachnoid space, subarachnoid space. But we are not talking about the subarachnoid blood. So in the dura, what we call the subdurals, the acute subdurals and the chronic subdurals, they are in between the arachnoid and the dura proper, right? So in acute subdural hematoma, source of blood is not the bridging vessel usually. In a young patient, the acute trauma can lead to either the injury to the brain parenchyma itself or the blood vessels, and any blood vessel can tear and starts oozing out. And you mentioned the Monroe-Kelly doctrine, that the skull, the brain is inside a closed box. There is brain, blood, and the CSF. So when there is a one component, the other squeeze in to give to compensate that process by giving space by squeezing, and that's very alarming, because the young patient, when the brain is already full, the potential to accommodate extra blood is not great in young skull. So there is a very limited space compared to elderly when they get chronic subdural, which is a very different disease, because with the shrinking brain, the space between the arachnoid and the inner dural membrane becomes more prominent, and the bridging veins, which traverse through the cranial cavity, through the bones, by either by the sinuses or by the transcalvarial veins, the chronic subdural happens, and usually the source is the venous bridging vessels, right? While in acute, it's arterial blood, and it's a very fulminant process, and it causes the raised ICP in an acute fulminant way. That's the difference. So we are dealing totally two different subdural diseases, two different diseases. One in young patient, acute trauma, arterial source as the source of blood, and while the chronic subdural in elderly, in a atrophic brain, the source is the bridging vessels, right? So this is the fundamental difference between these two. So I think your exposure to neurosurgery, I don't know how many cases you have seen. Do you want to comment on that? Did you get a chance to
had
see?
recently,
Mm-hmm.
yeah, I had recently a rotation in University of Belgrade, and I have also been in University of Nice. But the thing is, I haven't seen the emergent cases, and that's where I have seen like disc herniations. I have seen uh, craniosynostosis cases, as well as um, cervical cases. So mostly relevant to spine, and the cranial cases which were not quite related to subdural topic.
So basically, that was the main reason why you went into too much things in your first presentation. So I would recommend you select the small topics, concentrate on basics first. Don't jump into the clinical entities because your exposure is still very limited. So you cannot start with the clinical things. And since the basic neuroanatomy is more important for you right now. Okay, first you
Yes.
get master of it, choose those areas, then maybe the imaging topics like why the acute blood appears white on CT and the chronic blood appears the isodense.
Dark.
So that sort of
Yes,
explanations. So first anatomy, I would suggest you to pick those topics first. Try to understand the different in-depth features of every layer, starting from the scalp. So if you are picking up the layers of the scalp, you go through all the external carotid artery branches and vascularity of the scalp. And you try to understand and you try to define the extracranial branches going into intracranial and the anastomosis level between internal carotid and external carotid branches. So when you are finished with this scalp, then you pick the internal carotid branches, the brain anatomy, different areas and different vascular patterns if you want to go into the vascular details. But it's mandatory to have the complete sulcal, gyral, and then arterial and venous anatomy understanding before you jump into surgical techniques, because the burr hole is reserved. Burr hole is not treatment for acute subdural hematomas. When there is acute subdural hematoma, you have to either have a very small one and intracranial pressure is within the limits and you're treating non-operatively until the ICP crosses to a limit, or clinically you see the herniation signs. So the herniation also is a very late and advanced feature. So before that, you have to decide if you were conservatively treating some patient. And do you know what is the limit of intracranial pressure and how you monitor that? Again, that is also the basic thing. So you have to go into ICP, how it builds up, what are the limits, how you interpret different CSF compositions. So that would be more helpful. That's my suggestion.
yes. Thank you, Dr. Atawat.
Because now we have little confused picture of acute subdural and chronic subdural in terms of etiology. So we have to clearly define these two. So now we have a new baseline that we are dealing to different diseases. One is acute subdural, the other one is chronic subdural. The population involved is different, the anatomical details are different. So usually if we go into hematomas, so either you pick all the traumatic hematomas first, and the spontaneous later on in different talks. So in that way, you can cover all the traumatic findings, which is a different disease than the spontaneous. So every aneurysm, every AVM, every I mean chronic subdural pathologies, all are they all are different topics, and they need a totally focused review for that to avoid confusions. So otherwise, you have covered every concept. So and it's an excellent effort. But for the next presentation, you have to choose the anatomy first, go through that, and then move to clinical side.
Yes. Yes.
Thank you.
Thank you.
If you get chance to attend emergency, you try to go through the clinical presentation modes, try to see how the emergency management is done, and how the neurosurgical team acquires various steps, like getting a CT scan, decision for intubation or not, and then taking patient to directly operating room or initially intensive care monitoring. So in your setup, if they are doing ICP monitoring on a regular basis, I'm sure they would be. So in places like in lower middle income countries, people don't have financial feasibility and availability of ICP monitoring. So again, ICP monitoring is also done by different sort of anatomical places. So the sensors in terms of ICP monitor are being placed either subdurally, intraparenchymally, or intraventricularly, and you follow it like this. CVP monitoring is routinely done in ICUs. So in the exactly the same way, you see the ICP changes, and the normal ICP levels. Do you want to share the CSF dynamics? What are the
It is
pressure
in
dynamics of
accord.
CSF?
Is it, I'm not sure, but is it 15 to 30 mmHg, which is the pressure for the ICP intracranial pressure? And according to the Monroe-Kelly doctrine, I think the 80% brain, 10% CSF, 10% blood is what I like have as the parameters, and the 15 to 30 mmHg as the ICP which should be maintained. Apart from it, can you please specify which other parameters I can then try to comment on that?
So, Byam, do you agree with the ICP levels? The ICP normal range. Yash, do you agree with the? It's usually 5 to 50 centimeter in normal physiological conditions. So you monitor it, you keep a threshold during the monitoring. So as I said, the ICP for coning is like a very advanced process. So when acute subdural happens, it's not just hematoma, it's also the brain edema and a lot of secondary changes in whole hemodynamics, which leads to the ICP progression, and you mentioned that avoiding hypercapnia. So, so that's one talk should be dedicated to CSF dynamics. What is the normal ICP? What are the ICP waves? Also, how to monitor ICP, and what are the patterns, the waves of ICP, different waves. So those would be interesting. So my suggestion would be to keep things basic, simple, and step by step, rather than going into too much surgical details at your stage when you have no exposure clinically. You would invite troubles going into areas where you have not gone yet. So it's better to keep yourself strong foot at your basic anatomy and physiology and pathophysiology. And then it comes to the clinical and operative side.
Okay, thank you.
John, do you have any comment?
Yes, very good. Does anybody have any comments that they'd like to add? Byam, would you like to say anything? I'm calling on you. I'm sorry. I'm doing this. She just moderated a webcast from Yemen. She's a medical student. And what year are you? Your last year, correct?
Yes, correct. Yes.
Do you have any comments on how it's going, or what you'd like to see maybe in future webcasts? Because we really want to make this a medical students forum, right, Atta? We want you guys to give you guys what you want, and not going to dictate, things to you. So we would like to hear from you.
So I'm not discouraging my comments. Please, Rohan, please don't take it negatively. Oh, okay. Go ahead, Byam.
Yeah. So I was saying, first of all, thank you so much, Dr. Rohan, for this session. And thank you, Dr. Bahati, for the feedback, because we're all learning from the feedback, not just Dr. Rohan. And I'm looking forward to our future sessions as medical students. I have a bunch of ideas that I can share with Dr. John, and if he's okay with it, we can definitely proceed. They're like a lot, they're around above 90, so I can't just go over them right now. But yeah, I hope we all benefit from them. And thank you so much, Dr. John, for the introduction.
Yeah, and this is the group we're now known as the India Neuromed Student Group. And Yaz is going to be a big part of it and help me build a channel for all of the neurosurgery students, the students that like neurosurgery in medical school. And there seems to be a good community. We just need to draw them together. And I think having a board certified brain surgeon curating your talk, it doesn't get any better. I wish I was a kid again learning. I mean, you guys, because just imagine you're dissecting something and it's a board certified neurosurgeon over your shoulder while you're studying that. Now, how is that going to improve your education? This platform, you're going to see it's amazing. It has tremendous potential, and we really want to make it work for the med students that love neurosurgery. Okay, Marco, you have something to say? You look like you have a question or something. Go ahead, Marco.
Hi.
Introduce yourself, please.
Yeah. Thank Dr. Rohan for inviting me here. My name is Marko Todorovic. I'm a resident from the University Clinical Center of Serbia in neurosurgery. I'm very delighted to be here with all these young, enthusiastic, ambitious people, as well as with Dr. Bennett and Dr. Bhatti, who are well proven neurosurgeons. Thanks, Rohan, for this amazing lecture. You took not one, but you took two very big entities, and you draw good parallels between them. But those are, well, let's say two kind of even though they are in a same space, they are a completely different in terms of, well, etiology, pathophysiology, and in the end in terms of surgical resolving of them, in terms of the of how big the surgery it is itself, and how the results of the surgery, how they go in terms of acute subdural hematoma. We're usually talking about a very severe polytraumatic patients, which require much more than the chronic subdural ones. And in that term, I completely agree with Dr. Bhatti that there should, if well, this is my first time here, and thank you for having me. I'm not sure if I got into the mid of this series, or is just the beginning, but I
Just begin.
completely agree with Dr. Bhatti that if you guys are planning something like this, it should go from the top to bottom, so from anatomy to physiology, and then eventually to pathophysiology, surgery, etc. It's the way all the books are based. So it does make a lot of sense, and I wish you guys all the best. I would be also very happy to participate in this as much as I can. Um, I apologize for my black background, but I'm currently on vacation and I have a baby sleeping inside, so I had to improvise. But it was really cool. So yeah, please call me again.
So
Yeah,
Marco, John, go ahead, please.
I'm sorry.
John, go ahead. So Marco,
you're welcome to come, Marco.
Yeah, thanks.
And
Thanks.
spread the word that this is going to be consistent. We're going to be here. We haven't decided every week, every 2 weeks. I'd be glad to do it every week.
Sure.
For medical students, we're aiming for India to start, but we can have Serbia neuromed students. We can go to any country, but we'll start with India because there's such a large population. And we have a team now of Yash, Rohan, and most importantly, Atta Bhatti, that are going to determine the direction and the content. It's not me. I'm not a neurosurgeon. So we're going to meet together after the webcast and discuss what we want to do next. So we have a good team to start, and we're going to try to use this technology to spread the word, essentially. Okay, I think, is there anything else to cover, you guys? Atta or Yash or Rohan, anything we need to cover?
thank you, Marco, for your comments. I guess you are in mid-training years or senior.
Exactly. Yeah, I just started my 4th year.
Okay, so you're about to become a consultant.
Okay,
It's a 5-year.
We'll
5-year
follow and
neurosurgery
chronicle
program.
your career.
It's 6 years in Serbia, so I have 3 more left.
Right. So you are about to become chief resident.
Yeah, hopefully.
Okay, it's very good. And yes, I totally agree that going in a sequence from anatomy, basic anatomy, would make it even more exciting. But Rohan has done a very good attempt. It's his first talk, so I would give him very good marks for this first brilliant attempt. And the whole idea is when you are junior, you are not entered into residency, you have more space to make mistakes, and we learn from the mistakes. And it's not something a failure, it's like a process. So even the junior residents, they sometimes get confused differentiating between do on scan that if it's a acute subdural or subacute or chronic. So it's little bit whole two different pathologies. So I'm sure Rohan will pick two different lectures for covering the details of acute and chronic. And I suggested him to pick traumatic and non-traumatic. That
Okay,
would be it.
okay, very good. I think we need to wrap it up. Thank you for the initial episode of the India Neuromed students, and we'll be seeing you. We'll discuss later how often we're going to do it, etc. So thanks for coming, and please stick around. Thanks to Yash,
Yeah.
BM, of course, Atam, and Marco, thanks for joining us, and of course, Rohan for putting on a dynamite presentation. And stick around. Thank you.
Thank you.
Bye bye.
Thank you.
I'm just stopping.